Hello, you're very welcome to MSK Rad videos. This is the first in a series of short tutorials on trauma of the spine. I'm going to start with thoracolumbar trauma, and we're going to be thinking about how bone and ligamentous structures fail under forces and the different way that they fail depending on the direction of the force. And the reason why that's important to know is because if you can identify patterns of the way that bone fails on a CT scan, you can predict the mechanism of injury which has caused that spinal injury. And if you can do that, then you can predict which structures that you can't see so well on CT, the ligamentous structures, you can predict which ones of those are likely to have failed as well. Now, bone can break by being compressed or by distracted. So you can pull a bone apart or you can crush it. Ligamentous structures you can only disrupt by pulling them apart, by distraction. If you compress a ligamentous structure, it won't break. And that's an important distinction when it comes to looking at axial compressive fractures of the spine. So let's kick off with the first case. And no prizes, of course, for identifying where the fracture here is. But I just want you to look at this and just think about what mechanism of injury has sustained this fracture. And what would you call this fracture? Do you have a name that you'd apply to this type of fracture? We'll go to the axial slices. And the appearances on the axial slices have got a very characteristic pattern with the posterior wall here fractured in and almost completely obliterating the spinal canal. But also note here that there's a fracture through the lamina at the back. Now I'm seeing that fracture on all the axial slices as I run up and down through the fracture. And what that means is that that's a fracture that's running longitudinally. In fact, it's quite difficult to see that fracture on the sagittal slices because, of course, it's running up and down. So a fracture that you can see on a number of sequential axial slices means that the fracture is running longitudinally. If it was running horizontally, you, of course, wouldn't really see it on the axial slices because one minute you'd be on the fracture and the next minute you'd be off it. But you would see the horizontal fracture on sequential sagittal slices. Now, this is an axial compressive fracture, so the forces come straight down through the spine, and this is a burst fracture. And what this means is that the force has gone down through the posterior elements as well, and the posterior elements have been crushed just as the vertebral body has. And of course, the vertebral body and the lamina and the pedicles are a ring structure. And just like any other ring structure, like the pelvis and lots of other areas in the body, if you break it at one point, here, of course, in the vertebral body exploding outwards, it also gets disrupted at the back. So this is an example really of a sort of true axial compressive force coming straight down through the spine, sort of thing that if a patient jumped off a motorway bridge, for instance, they could sustain this sort of injury. Now, because this is an axial compressive force, the ligamentous structures at the back are intact because you can't break ligamentous structures by compressing them. You can only break them by distracting them. And that's why a burst fracture is essentially a stable injury. We've got a separate fragment here, but the anterior longitudinal ligament will actually be attached to this fragment here. The posterior longitudinal ligament is attached to this posterior fragment, and the posterior ligamentous structures are intact. And we can actually see the posterior ligamentous structures on a CT scan. And I want you to look at the epidural fat here and notice how it's clear and it's nice and black, and you can actually see the outline of the ligamentum flavum. This is important for when we come to looking at flexion, distraction, chance type injuries. So we'll move on to case number 2. Just to say, on this sort of burst fracture, if we do an MR, and in fact, here is the MR of that case, we're not actually doing the MR to look at ligamentous structures because we know that the ligamentous structures are intact. What we're doing the MR for is to see what effect the burst has had on the neural structures, and on this case, the conus. The spinal cord and the conus, of course, are very easily injured on a burst fracture, whereas the cord equina is much more forgiving. So we'll move on to the second case. And this is a slightly different appearance. We've still got compression of the vertebral body. We've lost height of this vertebral body. But in this case, the loss of height is more anteriorly than it is posteriorly. But there is still some loss of height posteriorly. You can see here that there's a slight buckling of the posterior wall of this vertebral body, whereas there's quite a lot of loss of height here. Now, this is, again, a compressive, axial compressive force that's come down through the spine, but in this case, it's come down rather more anteriorly, which is why we've lost height anteriorly more than we have posteriorly. But the fact that we've pushed down the back wall is a very reassuring sign, because it means that the posterior ligamentous structures will be intact. It's impossible to compress and distract the posterior structures at the same time. So you either compress them or you pull them apart. And if you've compressed down the back of the vertebral body, then you can't have pulled the posterior structures apart. So this is a stable injury. And again, if you notice, the epidural fat is clear here, and we can actually see the outline of the ligamentum flavum. So again, this you could term this an incomplete burst fracture. There's no fracture through the lamina at the back, but there is a compressive force that's come down, and it is buckling the back wall. So if you move on to the third case, and just ignore the spinal fixation lower down, that's not of any relevance. And the first thing I'm noticing here is there's very slight loss of height anteriorly, but the posterior wall is intact. And I'm noticing here that there's a horizontal fracture through the spinous process. And this is a horizontal fracture, and therefore this is evidence that the bone has been pulled apart. So this is a distraction injury. So this is a flexion distraction injury. The ligamentum flavum will be intact above and below because it's attached to this fragment. And in fact, you can see the ligamentum flavum is intact. So I can identify exactly where it is because it's outlined by the epidural fat. So this is a chance type injury, a bony chance type injury, because it goes through the spinous process. It will carry on through into the pedicle, in this case on both sides, with only a very small amount of crush of the anterior aspect of the vertebral body. And there's a basic principle when it comes to spinal trauma, and in fact, not just spinal trauma, it applies elsewhere in the body as well, but the greater the degree of bony disruption, such as in the case of the burst fracture, the less likelihood that you'll have ligamentous disruption. And the feature of the flexion distraction chance type injuries is that you often get very little in the way of crush of the vertebral body anteriorly. This principle does apply to other areas of the body. Think about the knee, for instance. Think about tibial plateau fractures in the knee. For years and years, we never used to do MR scans in patients with tibial plateau fractures, but now everybody gets an MR scan. And what we find is that they don't have disruption of the ligamentous structure. They may well have meniscal injuries and meniscal contusions, but they don't have ligamentous disruption. Whereas, classically, a patient with an ACL rupture will have no bony abnormality, or they may have just a tiny little avulsion of a small flake of bone, the second fracture. So it's the same sort of a principle that applies in the spine. Now let's move on to case 4. And have a look at this and see what you think. I'll just walk slowly through this. Okay, so clearly we've got a horizontal fracture, which is just going through the pedicle. And on both sides through the pedicle. But it's not carrying on through the spinous process. It's actually, the cleavage plane will exit through the soft tissues. So in this case, we can predict that the posterior ligamentous structures between L3 and 4 will all be disrupted. And in fact, you can see that on the CT. If you look quite carefully, can you see that this is what we call dirty fat, that we've lost that clear fat plane in there. Look at the level above. Of course, it depends, how much epidural fat you have. And unfortunately, some people have a lot of epidural fat, and it makes it very easy to see the ligamentous structures, and some people don't. But this is evidence here that the ligamentum flavum has gone on the CT scan. So if we look at the MR scan for this case, we look first on the T1. I'll be looking for that dirty fat sign. So I'll be looking to see what the epidural fat looks like at that level. And one of the reasons, of course, that we do CT and MR, the complementary tests, is because it's actually quite difficult sometimes to see whether the bony fracture is on the MR. But there's that little thing that we saw on the CT buckling into the epidural fat, and that's actually the disrupted ligamentum flavum. So that's the T1. The STIR sequence, of course, is one of our standard sequences, of course, for trauma of the spine, trauma generally in bones, and lots of other pathologies. And this is the evidence of disruption of the posterior ligamentous structures here all the way through. This high signal and disruption. We've lost the normal black line that we're seeing elsewhere. So that's a flexion distraction. And you see here, there is absolutely no compression of the vertebral body. And this is because the fulcrum of flexion is actually been anterior in this case, so that the spine has bent over, pivoting around anterior to the actual spine. So it's not compressed the vertebral body down here. So let's move on to the next case. What we see here is what appears to be an isolated fracture of the spinous process. Now, fractures of spinous processes are very common, and we most commonly see them in the thoracic spine, where the spinous processes are all very close together. And so it's very easy to cleave off a tip of a spinous process by compressing it between adjacent spinous processes. And that happens with true axial compressive fractures down through the spine. So you'll frequently see multiple, in fact, thoracic spinous process fractures. Now, if you look at this here and try and decide, well, firstly, I can see it on all the sagittal slices, so it looks like it's a horizontal fracture, although it's slightly obliquely orientated. If you imagine that this had happened because this spinous process and this one had been compressed together to cause that to cleave off, it's very difficult to imagine how that would happen with such a wide gap. This is a relatively young individual, and for this to come down and this to come down and to cleave off that spinous process would be very, very difficult. And that would not happen without the vertebral body also collapsing, and we would lose height posteriorly of the posterior wall. So again, this is a flexion distraction injury. And the important point here is that this doesn't just stop here. The cleavage plane doesn't stop there. It carries on through the soft tissues. And again, we've got the dirty fat sign here on CT. Can you see this? We've lost that nice fat. I haven't been concentrating on the coronal sequences so far, but in fact they are very important, and you should always look carefully for the alignment on the coronal sequences. And if we look on here, on these coronal sequences, what we see is the spine is bent over to the right. Do you see that? What this is implying is that the force has been applied to the body from the left side. So we would be looking for rib fractures on the left, scapular fractures, lung contusion on the left, because this is a lateral flexion injury. Not only has the spine been bent forward, but it's been bent forward and to the side. And when I come to the MR, I can predict that what I'm going to see is I'm going to see a lot of disruption of the soft tissues on one side, more so than on the other. So on the left side, I see all of this edematous changes in the soft tissues. If I go down to the right side, I see much less. And what I also anticipate is that the ligamentum flavum will be ripped on the left side, which it is indeed here. But as I go towards the right side, I can see that it's intact. So the instability here is going to be one of the patient tipping over to the side rather than tipping straight over in a true flexion distraction injury, because the ligamentum flavum is intact on one side. And I got all of that information from the CT scan by the fact that I looked carefully on the coronal images and I could see that it was bent over. The alignment was abnormal in CT, and that's such an important thing to do. And the important principles here really are that you really want to make the diagnosis on the CT, because looking at the MR scan can be difficult. And if you can predict what you're going to find on the MR scan, if you know what it is you're going to find, you're much more likely to be able to make that diagnosis. Okay, I hope that was of some use to you. If you're watching this on YouTube, do consider heading over to mskradvideos.com, where all these YouTube videos are freely available, but there's also freely available downloadable course material, which will help you with claiming your CPD points. And if you enjoyed this, then do stick around for the further tutorials when we'll be looking at further examples of thoracolumbar injury, and then we'll be moving on to the cervical spine. But really the basic principles of the way bone fails applies in the cervical spine as it does in the thoracolumbar spine. Thank you very much.